After a big surgery, one of the first things a doctor is always on the lookout for is a fever. But what if I told you that not all fevers are created equal? For a surgeon, a fever isn't just a number, it's a clue. And you know what the most important part of that clue is? It's when it shows up. So let's dive in and see how surgeons decode these absolutely crucial signals.
You know, in the world of surgery, there's this classic saying that gets passed down from mentor to student. The day of fever tells you the cause of fever. And this isn't just some catchy phrase. It's a really powerful diagnostic rule that helps doctors solve medical mysteries right there at the patient's bedside.
And that really gets us to the main question here. Why does the timing matter so much? How can a fever on the third day after an operation point to one kind of problem, while a fever just 2 days later suggests a completely different and honestly, a potentially much more dangerous issue? Let's figure this puzzle out together.
The key to unlocking all of this, it lies in the body's own predictable schedule. See, after the stress of a big operation, your body goes through a series of really distinct biological phases. It's almost like the acts in a play, and each act has its own unique cast of characters that can cause a fever.
Okay, so this timeline right here is our roadmap. The first 3 days, that's all dominated by inflammation. Then, from day 3 to 5, we get into what's called the infective phase. And after day 5, well, we're looking at a time where mechanical problems, especially in gut surgery, become the #1 concern. Let's break each one down.
All right, let's start at the very beginning. If a patient gets a fever within the first 72 hours, most surgeons actually breathe a little sigh of relief. And you might be wondering why, right? Well, it's because it's usually not caused by a dangerous infection.
The thing to remember is that surgery itself is a huge event for the body. It kicks off this massive body-wide inflammatory response. The body just floods itself with things called cytokines and stress hormones because of the tissue injury. That process all by itself is enough to cause a mild fever, long before any nasty bacteria have a chance to even get started. So, if it's not an infection, what are the usual suspects? Well, we're looking at stuff like simple tissue inflammation, maybe a reaction to a blood transfusion, or even just an irritated IV line. But the most common culprit, by far, is something called atelectasis. And what's really fascinating here is just how simple this whole chain of events is. After surgery, it hurts to take a deep breath, right? So what does the patient do? They take shallow breaths. This means small parts of the lungs don't get enough air, and they kind of just collapse on themselves. It's a simple mechanical problem, not an infection at all.
Here's a perfect example. A patient has colon surgery, and on day 2, a little fever pops up. A quick exam shows some collapse at the base of their lungs. The treatment isn't antibiotics, it's just getting the patient to breathe deeply, to cough, and to open those airways back up. And just like that, problem solved. But as we cross that 72-hour mark, the whole story changes. That inflammatory phase starts to fade out, and a new group of characters comes onto the stage, bacteria. This is when the risk of a true infection becomes very, very real.
So why day 3? What's the magic about that number? Well, it's all about the bacterial life cycle. Even if some bacteria get into a wound or the urinary tract during the operation, it takes them a couple of days to multiply into an army big enough to overwhelm the body's defenses and trigger the fever and all the other symptoms. That incubation period is exactly why day 3 is such a critical turning point.
So this brings us to a whole new lineup of suspects. The focus now shifts to things like pneumonia, urinary tract infections, maybe an infected IV line, or the surgical wound itself. And here, we're dealing with specific bad guys, like E. coli in a UTI, or Staph aureus in a wound.
Here's a classic case for you. An abdominal surgery patient is doing great until day 3, when boom, a fever shows up, along with a new cough. The timing, plus the cough, points the doctor straight to the lungs. The diagnosis? You guessed it, postoperative pneumonia. Okay, now we are entering what is, for any gastrointestinal surgeon, the most high-stakes period of them all. A fever that pops up on day 4, 5, or 6, that sets off an immediate, serious alarm. When a surgeon has operated on the bowel, they live in fear of one specific complication, an anastomotic leak. And the classic time for that leak to show itself is right in this window. A fever now is considered a leak until you can absolutely prove it's not.
So what in the world is an anastomotic leak? Well, to put it simply, it's when the new seam connecting two pieces of your intestine fails. It comes apart. And this allows all that bacteria-filled stuff from inside your intestines to spill out into your abdomen.
This can lead to a really life-threatening infection called peritonitis.
But why day 5? You'd think a wound would just get stronger every single day. Well, this is where we see this fascinating little paradox of healing. For the first few days, the stitches are holding everything together. But around day 4 or 5, the body starts remodeling the wound. It actually breaks down the old collagen before it lays down new, stronger stuff. And in that brief little lag phase, the connection is at its absolute weakest point.
Let's look at a case file to see how this plays out. A patient who had surgery for rectal cancer seems to be recovering just fine, but on day 5, they suddenly spike a fever, their heart rate shoots up, and their belly starts to hurt. That trifecta of symptoms is a classic sign. A CT scan is ordered, and it confirms the surgeon's worst fear, a leak.
And believe it or not, the diagnostic timeline doesn't stop there. Fevers that show up even later in the recovery process, say after the first week, well, they point to a whole other set of problems.
So from day 5 to 7, we might be looking at deeper, more organized infections like an abscess that's been forming. And after a week, the causes change again. We start thinking about things like blood clots in the legs, which is a DVT, fevers caused by a reaction to a drug, or infections like C. diff that can happen after a course of antibiotics.
Okay, that is a lot to remember. You've got an inflammatory phase, an infective phase, leaks, abscesses. So how on earth do doctors keep it all straight in a busy hospital? Well, they use a simple, elegant little memory tool, a kind of secret code.
And here it is, the famous 5 W's of postoperative fever. On days 1 and 2, you think of wind, that's atelectasis in the lungs. On day 3, water, think urinary tract infection. Days 4 and 5, the wound itself. Days 5 to 7, walking, or really not walking, which can lead to a blood clot, a DVT, and then after a week, wonder drugs, a fever caused by a medication. It's just a brilliant way to organize your thinking.
But as we've learned, GI surgeons, they add their own crucial W to the list. For them, on day 5, there's another W that beats all the others. What did we do? That question is a direct reminder of the specific operation they performed, and if that operation involved the bowel, the answer is always, think about a leak.
And that brings us to our final and maybe most powerful piece of medical wisdom. Sometimes, even before the fever shows up, the body sends another signal, an unexplained rise in heart rate. Tachycardia on day 4 or 5 can be the very first sign of an anastomotic leak. It's a subtle but absolutely critical clue that tells a surgeon that trouble is brewing, and it leaves them with a question that demands an immediate answer. What is my patient trying to tell me?